First of all, thank you for having us. My name is Untitled Chapter. I'm a partner in our life sciences practice at Deloitte. And just because, I want to clear a couple things up, because sometimes when I walk into clients, the first question is, I don't really need accounting help, and I don't know why you're here. We are an accounting firm. We have our colleagues that do accounting. That is the historical legacy part of what Deloitte is. I am not part of the accounting firm, so if you have questions on your taxes or inversions or anything else like that, I'm the wrong person to talk to. I am part of Deloitte Consulting, which is one of our 4 groups, and I work specifically in the life sciences. I've got about 20 years experience in consulting in life sciences. I started out my career doing research in neurobiology at Caltech. I live now in San Francisco, but hopefully you guys won't hold that against me, because I actually grew up here in Southern California, went to high school in San Diego. I'm one of those refugees that would love to get back to Southern California at some point. So in terms of my own background, I started out doing work there. After that, I've done work in all of the major sectors that we have. And for Deloitte, what that means is, when we talk about healthcare, we have 4 major sectors. And you're going to see that in some of the presentations we're going to talk about here. We have our provider group, which works with hospitals and other organizations that provide health care. We have our payer group that handles the insurance and sort of the parts of the organization that are actually responsible for the financial intermediaries that are there. We also have our what we call life sciences, which are the people that supply products and services in this space. So that would be the biotech, the pharmaceuticals, the medical devices, the life science tools, other parts of it. And then definitely last but not least, we also have our federal and state practice, which is, as we've talked about earlier, there's an awful lot of involvement of the government, both as a payer, as well as a researcher, as well as a regulator in all these areas. So I'm going to then just dive into this, and I apologize for some of the denseness of some of these slides, but we'll hand it out later. But I promise you I won't try to make this death by PowerPoint as we go through it. So let's talk a little bit about healthcare transformation. We've had the discussion before about things are changing. Well, let's ask the question, why? And I can go through an awful lot of detail on this slide about why things had to change. Let's start with the brass tacks. It just costs too much today. If you look at how much it costs us to per capita basis compared to almost all of the other developed countries in the world, we aren't leading by a little bit, we're leading by a lot. And that's a real issue, especially as our population gets older. These numbers are not going to go down. They're going to continue to grow unless we do something pretty dramatic. Now, there's some other issues out there. There's issues around access to care. There's issues around quality. I always find it very interesting when people talk about U.S. having the best healthcare system in the world. You know, it's a nice talking point. Sometimes it's used for political reasons when they say that. In reality, when you take a look at the international studies that are done, it's nowhere even close. In fact, in certain places, we are behind places like Cuba in terms of things like infant mortality and such. And then the last but not least is the experience issue. For those of us who have had to deal with healthcare, I think that, I think we have about a 45%, which last time I was in a academic setting, that usually translates to an F in terms of a grade that we see. So the challenges are there, but I don't want to get away from the fact that cost is the big driver. All right, so there's a lot of things that are happening. We've talked about some of these. I'm not going to spend a lot of time on this slide. But when we talk about it, there's obviously issues. We just talked about some demographics and aging. There's issues around the debt levels that we can sustainably move forward with, both from a federal and state level. There's issues around the U.S. economy, how fast we're going to be growing, and the fact of global markets, which means that a lot of my clients don't necessarily think of the US as the best place to go and put new investment when they have an opportunity. And part of that can be driven by the fact that healthcare costs.
But technology, I think, is one thing that's interesting right now, is that's actually changing really the delivery model for healthcare. And when we think about some of these things where you can reduce cost, you're going to have to rely on technology to be able to do that. So can we do remote monitoring? Can you shift more care to a home setting? And even our provider clients are trying desperately to figure out how do they do that, because keeping somebody in the hospital longer isn't necessarily the way for them to make money now. And we'll talk a little bit about that why. So I think technology is really going to become the enabler for some of this.
Okay. So, and then when we talk about healthcare reform, just to be clear about it, just so we're all on the same page, the big part of that gets a lot of news and you hear on is the ACA, the Affordable Care Act. That is just one piece of the legislation that's going through. It's more than just about the ACA that's causing it. There's issues, we talk a little bit about the HITECH Act and how it helped set up electronic medical health records. There's also issues around CHIP, which is for insurance for children and such. Our ICD-10 legislation. There's a whole series of these things happening. So it's not just, I mean, we're going to talk about it as reform, but understand there's a lot of moving parts underneath it. Okay, so what do we see sort of happening in terms of the changes? I'm going to just rattle off through a few of these things, and the point is not that all of them are happening at the same pace at the same time, but that they're all happening and they're all moving. So the way to think about it is that we definitely are seeing consolidation occurring, okay? And it's happening from plans and providers, right? Just a quick question for you, just to see how you guys think about this. What percentage of new physicians, those just brand newly coming out of medical school, are going into private practice these days?
I'd say about maybe 5 or 10%.
Yeah. Any other ideas?
Yeah, I would have thought much higher.
No, there's no money in it.
Yeah. It's in fact, what's happening is that our physician population, we've already known this about nurses and other technicians, have been employees, the vast majority of them. Our physicians are increasingly now also becoming employees. And they're becoming employees because consolidation is happening. Because providers are going out and actually buying up physician practices. So all of a sudden you go from being an independent businessman to being an employee of a larger entity.
Yeah, they're better off serving in the military as a physician, quite frankly. Dr. mentioned.
Yeah. So that's the first thing. Second thing is guess what happens when you become an employee? You no longer have as much latitude to make your own decisions as you used to when you ran your own shop. So it's moving from being a physician-driven world where decision-making is pretty much, you have to convince the physician, and if you convince the physician of what you want to do, everything happens, to now it's being driven by guidelines. And these guidelines are being instituted not by, sometimes with physician input, but not entirely by physicians themselves. Reimbursement, we've talked about it before. It's moving from you're going to get paid for the amount of procedures you do to the outcomes that you generate. Okay? I often refer to this as, this is moving from going to your dentist, who gets paid for every time they clean your teeth, right? To now getting paid for how happily you feel about going to the dentist every time you do it. So it's a bit different. We'll talk a little bit about transparency in that all of a sudden, using the term quality in healthcare up until a few years ago was sort of an oxymoron. I mean, you really couldn't, if you couldn't measure, you didn't know what was going on, it was impossible to figure out, what was happening. Well, all of a sudden, lo and behold, we're going to show you some data on it. The metrics are starting to become a lot more important. And then physician access. This is one that, and I'm going to talk to you about it right from the life sciences company perspective, as opposed to, there's two parts of physician access. A, the patient, can they see their physician that they want to go see? We can have a lot of discussions around what healthcare reform is going to do, but at the end of the day, let's be really clear about it. You are not going to be able to go see any single doctor you would like to out of the United States, under any scenario or system out there, unless you're basically willing to reach into your own pocket and spend the money for it. That's the first part. The second part is, for those of you who work or have seen as a pharmaceutical company, or as a medical device company, or as other providers that supply some of the technology that's there. I remember when I was doing medical research when I started out, and I was at a major academic medical center, we had roughly, I mean, it was great because I was a poor, starving graduate student, so it was, you know, whenever the pharma rep came around, it was great. There were donuts, and there was coffee, and there was everything set up. And you could go in there and get whatever you wanted to, and that was like better than having to buy your own breakfast. Nowadays, we don't see the ability to do that at all, if any at all. I mean, people like Kaiser, you're basically not allowed to wander the halls if you work with any of these suppliers and providers. Well, what impact does that have? What that means is that all of a sudden, you're going to have different ways of convincing people and showing people what the value is of any kind of new product or service, including IT, that you're going to be selling into this marketplace. All right, this is really complicated, but this is sort of a game board. Think of it this way. Along the side over here, here's the traditional sectors. We basically have our government on this side, and then on this side we have what's happening. So what this is really sort of showing you in sort of a graphical way is that everybody is trying to become like everybody else in this market, right? We're starting to see people that are, you know, frankly, that used to be, you know, financial services companies, the payers, the guys that, you know, employers, the people that just paid for the healthcare, are starting to, I'm just going to pick one as an example here, are starting to go and actually work and set up deals with pharmacies to set up educational and counseling services. Because one guess about how much, one guess from this group out here, about what percentage of the people that are given a prescription for a drug. So these are folks that have gone in to see their doctor, they've gotten a prescription, they've actually gone and filled the prescription at a pharmacy. What percentage of them actually take the drug?
20%, 60?
That's it, 60%.
I don't think so.
But imagine that. You've already paid for it, the whole system is paid for it, obviously you need it, and only 60% of the people are actually taking the drugs they're supposed to be taking. Well, guess what? If you're a payer, the ultimate payer, you're a company that's paying for their health care, if your employees are not taking the drugs they need to be taking to make sure that they're well, so they're not taking their diabetes medication, they're not taking their asthma medication, and they're not able to show up for work anymore, you're going to feel the impact of that. So rather than just sort of be a sort of someone that's reacting to it passively, they're starting now to get involved and actually negotiate deals. So the pharmacist can actually go in there and coach you of how to take your medication and to ensure that you are indeed taking your medication.
And I think this is where there's a huge opportunity for how does technology foster some of these new business services that really are, there's a big gap right now. And if you look at some of the convergence opportunities to really impact patient care, that's where enabling technology and getting it in the hands of both the provider and the patient and getting them better connected and better collaborated is where there is, you know, significant opportunity for new businesses as well as being able to drive costs down and improve quality. So we definitely see a lot of really interesting partnerships and things that even 24 months ago you wouldn't have imagined. The other is just, you know, just the convergence alone where you see the providers and the plans actually merging together more and more. So what we envision is, and probably not too far out, you're going to see an environment that almost looks like Kaiser and a bunch of other mini Kaisers, you know, especially in the United States, really trying to drive that cost and quality objective as much as possible. You see that in a lot of the other single payer environments and other areas of the global economy already.
Yeah. And it used to be that the best thing you could do if you were a manufacturer, used to be that if you could convince a doctor to prescribe your much, much more expensive drug, I'm using a pharmaceutical example right now, than what was the generic drug or was on the formulary, it was a win for you altogether. Increasingly, what's starting to happen now is the incentives are starting to align within the organization. And so even people that produce drugs are starting to take an economic incentive as part of their contracts to actually make sure that the patients get well. So all of a sudden, that kind of behavior is no longer going to be the ideal behavior. Oops. Our IT department is making sure that I don't stay too long and lose data here. So, all right, so how is the value proposition shifting? So let me just stop here for a second. I mean, is there questions about the fact that this whole market is converging? I mean, and when we mean convergence, we're not just talking about convergence across just one part of the thing, but the entire market is converging. Is there any questions about that before I rattle into sort of, because if you accept that premise that things are converging, then we're going to talk a lot about how value propositions are shifting. Okay. All right. So the first thing is the value proposition is that it's value over volume is what's happening. And there's a lot of reasons for that. We've talked about it. I'm not going to spend a lot of time going through these again with you. But we talked a bit about the fact that EMRs have been sort of the critical part of now starting to get data and information about what's going on. And we've talked a little bit before about the collaboration that's going on between the various players in the healthcare system. But in terms of what's going on here, I apologize for this slide being so dense, but I wanted to give you a real-world example of something that's happening to a provider to explain, to show you why things are changing, why the value proposition has to change in this new world. So what's happening is that value-based payments, everybody sort of, it's wonderful, it sounds, it should all be win-win, right? It's one of those kind of things that everybody says is the best thing that's out there. Well, let's sort of peel back a little bit of that and sort of talk a bit about, well, what happens to a typical hospital system under a value-based system? So there's sort of, 3 or 4 things that are starting to happen. So we're starting to see value-based purchasing. So the people that make the various products and services are starting to say, I'll go at somewhat at risk, but I want to get some of the upside as I go through it. I'll also start having bonuses attached to it, whether it's if I can demonstrate that I can reduce your overall healthcare costs, I get paid more. The government's coming in with a various series of regulations that are part of the Affordable Care Act that are saying that yes, I will pay you for outcomes, but I'm going to measure you on that, and I'm going to look at how your readmission rate is. And if people start bouncing back into your hospital again, it's going to be a penalty associated with it. I won't pay you as much.
Yeah, when you think that their margins are typically in the single digit already,
Mm-hmm.
and over the next 2 years there's 7% potential additional impact, it does make the value proposition for them being able to exist with any efficiency very low. So they've got to introduce efficiencies into that provider delivery network. You probably hear this constantly.
This is something that I'm sure that our colleagues from the provider, they know this intimately. But the last one that's up there is important: hospital-acquired infections.
I was just going to ask, the hospital-acquired conditions is infections.
Infections right now, we're going to show you how it's going to change in a little bit in a few years. But yes, right now it's infections. But that's basically a system that says if you admit somebody to the hospital and they pick up MRSA or they pick up any of these other kinds of conditions, and you have to readmit them because they now picked up MRSA, you no longer get paid for that second readmission.
Yeah, so some of this was already happening anyway with the but we're far along this continuum already of how much negative impact in reimbursements and payments has already happened to the provider sector. I mean, that's what I think folks don't realize and which is another reason why if you're already get close to where that max impact we expected in the next 5 years was, it's they're living it right now.
Yeah. And so, and this is for a 1,200 bed, this is a pretty big academic hospital. but they're looking at it in any given year. You know, we're looking at sort of in the 5 years there's about $80 million coming directly off of their top line revenue. That's that impact here. Okay, so apologize for that. But so what's going to happen moving forward? So I just showed you what a snapshot looks like today. What's going to happen as it goes forward? Well, the whole idea of putting metrics in place and looking at outcomes and sort of doing that, well, there's going to be different types of weighting that's going to be going on now, going forward under these healthcare reform, of how the hospitals or the providers are going to get paid. So right now, it's about 70% of the kind of the weights of what people are getting paid for is based on sort of the clinical process of care. How are you clinically doing things? Are you following protocols? Are you doing that? And about 30% of it is based on how the patient thinks, how they responded to that kind of care. You know, you survey them. Did you like it or did you not like it? Well, now, when we did FY14, another piece starts to be added in, which is now outcomes, right? And as we go forward, another piece which is going to be put in there is now around efficiency. So if you take a look at what it's going to look like in just a couple of years from now for the payers, for the people that are actually providing the care in there, only about 10% of what you're going to get, paid is going to be based on did you follow a protocol or not. That's going to be assumed that you did that. Everything else is going to be coming in. Now, what does that imply if you're in the IT and you're doing convergence? Well, what it means is just making sure that people follow what they're supposed to be doing is not going to be enough anymore. You're going to have to be looking at all these other factors.
And the data to be able to quantify that and measure it and back it up, to have the evidence-based data to back up your metrics.
Okay. This is, sorry.
Protocols would be then highly disciplined. I mean, very little modification,
So now if all the practitioners working in your environment are your employees, you can control that. In the old world, when it was
Right.
very dispersed and those medical practitioners weren't actual employees of that provider network or that hospital environment, you had less control over that. So now that's just a given. That almost comes off the table. So now, as a hospital administrator, I don't want to endorse any new scientific technology unless it improves patient outcomes and introduces efficiency, and there's an economic story associated with it.
So it's the cost of proof and validation will be an inhibitor to new products, services, and the like.
Potentially, if you
gotta
don't
have,
if you don't have that.
outcome-based data.
How would that work in California when physicians are prohibited to be employees while providing clinical care?
While providing clinical care.
Well, I mean, like Kaiser, they are. I mean, they obviously are employees of Kaiser. They're employees of the Permanente Medical Group, which is, which then contracts into Kaiser.
There are state laws that state that the medical staff has to be self-governed by the medical staff. That's why the medical staff reports directly to the board of directors to prohibit what you're talking about. That's not in all states, but I don't know which one.
So I guess the way we put it, and I'll defer a little bit to some of my colleagues that are not here, unfortunately, that are part of the provider practice. So there's a couple of things happening. So I agree with you. There are different state laws which put some red lines in place about what can and can't be done specifically to instruct physicians how to do medicine, how to provide medical care. Actually, it's for all healthcare providers, not just physicians. It's for all healthcare providers. On the other hand, there is also, so yes, those things exist. But what we're increasingly seeing, though, is that we are seeing greater use by regulators, including CMS, the Center for Medicare and Medicaid Services, and the FDA and other folks, that are increasingly looking at it and trying to and looking at the cost of being in non-compliance with a well-established clinical protocol. And what's happening there is that it's increasingly that what's considered to be good standard of care is now being protocolized. That's not a real word, but that's increasingly what's happening. So yes, there will still those rules and regulations on an individual state-by-state basis, but we increasingly see them as being less of a gigantic hindrance and more just the uniqueness between practicing medicine in Illinois versus practicing it in California.
Just a question for you. So obviously, you know, the providers are having to make their decisions based upon these changes. How do you think that's going to affect the payers' response? And I ask that question because if you look at the profile of health in this country and declining health and thinking that payers are then going to pay based upon outcomes, which is really outside the control of the providers directly, it's an individual thing most often. I'm just curious what your perspective on that.
So, you know, what you just put your finger on it is the biggest argument that usually tends to happen, I mean, between the two, right? So, I mean, you basically, you know, they're really, really insistent that I play along. Okay. All right.
Can't swing your back.
Okay. What I think is happening, and this is the kind of discussions we've seen happen across multiple medical specialties in multiple areas, that, you know, how can you judge me on outcomes when, and this is what the provider would tell you, this is what the doctor or the provider would say, when I'm working in an area that has, let's say, for example, extremely high levels of diabetes, right? And yet you're paying me for outcomes when I've got a sicker population starting out than somebody that works in a place that's got a younger population and a healthier population. And so those arguments are happening, and I don't want to discount those because they happen all the time. They happen across medical specialties, they happen across institutions, that they happen everything. But remember one of the first trends we talked about, which is consolidation? If you're big enough and you're pulling in your treatment from a big enough area, you can even out some of those changes that are actually occurring. So therefore, you won't just have only the sickest population anymore because you work in a large urban medical facility, but you'll also have basically a physician network that will also be out in the suburbs.
Well, and we see a lot more joint venture and collaboration and M&A, you know, activity between the payers and the providers in different areas of the country for that.
There's really not interstate competition yet between the payers.
True.
And so that's a huge roadblock to all of this.
We're starting to see, you're right, but we're starting to see a couple of the sort of the lighthouse areas, people like Intermountain Health, which is out of Colorado. Obviously, Kaiser is another one of those. MAMSI and there, I mean, you know, Mayo has a couple of these things. We're starting to see some of these institutions, again, start to become going across states, picking up people from different, you know, a broader pool. And the question is now going to become is, you know, what is the true value? And my payer colleagues would hesitate if they heard me saying this, but the question that always comes up is, what is the value that the payer is really providing anymore? If you've got these organizations that are providers that are actually taking on the economic insurance risk as well, because they're getting paid this way, what am I actually getting for Aetna? You know, or from these, is it just because they can process paperwork better than anybody else can?
That's it.
I mean, what am I actually getting for that? And so that's a question that the payers are also having to grapple with, is that where do I drive value as I go forward here? So when we talked about, well, how are things changing? Well, this is a little bit about, I want to sort of take, you know, this kind of thing that's, at this point now, what's happening is coming in and telling the healthcare system, you've got a better widget, be it an IT widget, be it a new medical device, be it a new drug, be it anything else, is no longer sort of the way of the world anymore. What's happening is that now everybody requires evidence generation. So you claim you have a new widget, and it's better. Prove it. Show me. Develop some evidence. All of these things get sort of put together, the stakeholders there, and as you're doing the